Hi, thanks for watching. Thanks for taking the time to hang out with me while we talk over epinephrine. Epinephrine's a great drug. It's a good drug to be introduced to, and tonight we're going to go over a quick basic rundown introduction of what epi is, why it's important to know it, what kind of class it is, the actions, the side effects, the type of patients, the dose, the route, the drug, the concentration. Just a quick, good review for some of you, maybe a quick introduction to the drug. So what is epi is a good place to start. Epi is basically a duplication or it kind of mimics adrenaline. It gets you excited. It's that hormone that gets that heart rate going, breathing fast. If you're getting ready to do something fun, maybe talk in front of a crowd, do some skydiving. It's basically what's going to get you pretty excited. And there's some unique properties of epi that we're going to talk about tonight. And the two unique properties of epi is it's a cardiac and a pulmonary stimulant that causes desired effects, and that's why it's beneficial in a variety of ways. So we're going to see the cardiac and the alpha-1 receptors, and what they are is, the receptors that sit out in the blood vessels, and when they get stimulated, these blood vessels are sitting out there and they constrict real tight. And so what that's doing is causing blood either to just fill up in those constricted vessels now, or shunt that blood from the extremities to the core part of the body, to those vital organs. So that's one unique property of epi. It's also, what else it's going to do with that stimulation of the cardiac is it's going to increase the heart rate. It's going to increase the contractility. You're going to see more demand because it's working harder, so it's going to need more oxygen. So therefore, it's going to need more oxygen. Basically, it's pretty obvious. It's like if you're a runner, the faster you run, the more oxygen you need. What else are you going to see with it? You're going to see an increase in the blood pressure. That's what we're looking for because we're constricting those blood vessels. And then again, it's that demand and the O2. And so that's the unique side of the cardiac. But the other unique thing about epi is the pulmonary side, the beta-2. You have those beta-2 receptors that sit in the bronchi of the lung. What happens when they get stimulated, instead of constricting like the alphas, they dilate. And so they open up nice and big. And so what we want is to get more oxygen, more air, more O2 to pass through into the lungs to hit down those alveoli and get that gas exchange so we can get oxygen in the bloodstream, that CO2 out, and kind of get that process going. And so that's what's unique about epi is it has those alpha-1 and the beta-2 receptors. So why do we give it? Typically, we're gonna give it people who really are having an emergent problem, a condition. There's a different variety of emergent pathways that we give it for, but it's for people who are sick. It's flat out. You take epi out, we're not giving it to a guy who just fell down and stubbed his toe. It's some serious conditions, and it's one of the first drugs we see in the ACLS algorithm, cardiac arrest, because it does its job. It's potent, it's strong, it affects those cardiac cells, and it also affects the pulmonary area. So what we're going to see is for people who are in asystole, PEA, and VFib, we're going to get 1 milligram at 1 to 10,000 every 3 to 5 minutes via an IV. And it's good to know that because there's different concentrations. The drug comes in different forms, and if you give the wrong dose, the wrong route, to the wrong patient, basically your 6 rights of medications, you can have a really undesired effect, and ultimately you're responsible for that patient's safety because you're bringing a drug into their body. But if you do it the right way, and hopefully we get the good outcome that we're looking for, you can save somebody's life, and it can be really beneficial. So it's good to be familiar, confident, competent in the drugs, and you can really have a positive outcome, hopefully. That's what we're looking for anyways. So cardiac arrest, we're going to see that ACLS rhythm, epi every 3 to 5 minutes, 1 milligram, IV, 1 to 10,000. And that's usually in a pre-filled syringe. It's in a box, tan, it will say right there. So it's always good to look at that box. Now, the other type of patient who's going to need epi is an asthmatic patient, people in anaphylactic reactions, where you immediately get that really loud, audible wheezing. You don't even need a stethoscope to hear it. They're just having a really hard time breathing. We give that sub-Q or IM, and we give that at 0.3 to 0.5 milligrams per 1 to 1,000. That's the difference. The 1,000 to the 10,000. The 1,000 is more concentrated. There's more of that drug in that space or that fluid compared to the 1 to 10,000. But we're not going straight into the IV, into the blood system, right into the heart. We're going sub-Q or we're going IM. So that's kind of where you see the difference in the concentrations. It's really beneficial for those people. You're going to open up that airway. That beta-2 property is going to open up that bronchi. You're going to get more air passing through. Again, it can go either way. You don't get that drug on board fast enough, those airways can close up. You could have to intubate somebody, or you put in 0.3 milligrams IM sub-Q and give them some epi, and it opens that airway up, and boom, wheezing's gone. So again, we're using epi for people who are really sick and who need our attention immediately. So quick review of that is 1 to 10,000, 1 to 1,000 cardiac arrest patients, 1 to 10,000 IV, asthmatic, anaphylactic shock. We're going to see 0.3 to 0.5 milligrams sub-Q IM, 1 to 1,000. With anaphylactic shock too, you can go into the IV and you can keep that dose the same, 0.3 to 0.5, but you're not going to give 1 to 1,000, obviously, right? It's concentration that'd be overkill. I don't know what happened, but it wouldn't be beneficial. So we could do that, but we're going to go with that 1 to 10,000. If it's really serious, that patient's really red, can't breathe, getting really little oxygen exchange, their status is going, we can go into the IV and we get that immediate reaction, but we're going to change the concentration. So it's really good to be aware of the situation, the patient, and the route, the dose, and which way we're going to go, so you grab the right drug. Again, the responsibility is on you as the medical provider. So what are we going to see when we give epi? There's the side effects of anxiety, palpitations, increased heart rate, increased blood pressure. But sometimes that's the desired effect that we want. And so it's good to know what the contraindications are, the side effects, and the desired effects, because sometimes in different situations they can all be the same. So a quick overview. Epi's a great drug, strong, potent alpha and beta receptors, stimulates the alpha-1, the beta-2s. We're going to see an increase in the heart rate, increase in the myocardial contractility, right there on your outline, systemic vascular resistance, increase in the blood pressure, also an increase in O2 demand. Make that heart work harder. It needs to be fed. It needs oxygen to work. And then also we're going to see that bronchodilation in the lungs. We're going to give for people in VFib, PEA, asystole. It's your, one of the main algorithms in your ACLS book. Also going to see it in anaphylaxis, asthmatic patients. Precautions, just be mindful if you're giving to a patient who does have cardiac history, why you're giving it, and is there a better drug to give to this patient besides the epi? Maybe there is, maybe there's not. Maybe it's just something that you have to know that it's there, but still move forward. Know your doses, your routes, your concentrations, the drugs, be confident, and know your side effects. But that's quickly a quick rundown. Again, epi's a great drug. Be familiar with it, because when we're going to use it, we're going to use it for really serious matters that depend on life and death. And so I hope you enjoyed that. I know it's quick, real basic. We can get really in depth. There's a lot more it can do, but again, this is just a basic rundown and a review, introduction of epi for the adult patient. Have a good night. Thanks for watching. Thanks for the time.